everyone. Lovely to see you all here. It's just coming up to 8 p.m. What I'll do is I'll just give a few more moments for people to join the webinar. I'm here at home at the moment. I managed to get home after the clinic today, so I could see you all from my house, so I can go straight to my bed after this. I'm sure you've all had busy days as well. If you could just raise your hands if you can hear me. So there's an option just at the bottom to raise your hand. Oh, Ryan's there. Oh, got loads of raised hands. Excellent. So everybody's awake. I know it's a late night webinar, but I tried to time it to coincide hopefully with after bedtime, because I appreciate that, although it's the summer holidays, I appreciate that sort of 6, 7 o'clock can be a busy time for families. That's why we're starting at 8. I'm really looking forward to this webinar tonight because it's lots of information that I give out to the patients that come to see me. It's information that I wish was more widespread and available to people, which is why I'm really excited to be able to present this to you tonight. There will be a recording during the session. If anyone has any questions, you can pop them in the Q&As section. And I have Dr. Ryan Jenkins here with me to moderate. I'll tell you a little bit about him as well once we get started. But for now, I'm just going to mute myself and have a sip of tea, and then we will get started at about a few more minutes. Let's aim for a minute or so more, and then we'll get started. Okay, any questions now, just let us know. Thank you. Okay, everybody, welcome to my webinar. And the webinar tonight is about enamel defects, but it's usually I lecture for dentists. But today I'm giving this lovely presentation for all of you lovely parents. I know there's a few dentists in there as well. You're all very welcome. This is the information that I wish people had for their children. To look after their children's teeth, to do an awesome job, because I know that that's what we're all striving to do. We all have the same end goal. As we're going through, you can put in your questions in the chat box. Dr. Ryan will have a look at them, who is my moderator today. Do you want to say hi, Ryan? Let's see your lovely face.
Hello.
Hello. Oh, can I hear you?
I don't know, can you hear me?
Now I can hear you, perfect. So if anybody has any problems as well, just pop them in the chat box and Dr. Ryan will flag it up to me if you can't hear or if something goes wrong with the presentation. But fingers crossed, all will go smoothly tonight. Yes. I've warned all my teenagers to stay off the internet. So we're hoping, hopefully everything will be okay. Right, here we go. So my name is Dr. Libby. I am a specialist in pediatric dentistry, and I'll just talk to you a little bit about who I am. I'm a mother of 3 girls. This is the latest photo which I managed to death threat my children and husband into taking with me when we were on holiday last week. A very, very short and quick break, but very nice. I'm a specialist in paediatric dentistry, as I mentioned, and I did my degree at the University of Edinburgh. I have a doctorate in paediatric dentistry. And I am very passionate about delivering oral health messages, which is why I've also done a postgraduate certificate in dental public health. I've also done a postgraduate certificate in medical education, which is all about teaching, which is another one of my passions. I'm very excited to speak to you because I'm such an advocate for oral health. I want to empower families to be able to give their children the best oral health care possible. I work at Sunrise Dental Clinic, which is in Edinburgh, Corstorphine, in the United Kingdom. I work alongside my husband, Dr. Mo Al-Muzian, which is very important and a unique aspect to our clinic because there's not many places where you can get a pediatric dentist in the UK working alongside a specialist orthodontist. We run lots of joint clinics, but really every day in our clinic is a joint clinic because we are constantly soundboarding off each other, working alongside each other to make sure that our patients receive a holistic care, which doesn't just encompass pediatric dentistry, it's also orthodontics. In addition, we have lots of amazing team members. We have our amazing nurses, our amazing admin staff. We have a hygienist team. We also have a specialist in oral surgery, Dr. Julie Burke, and Dr. Ziad Al-Ani, who has a special interest in TMD, which is our jaw joint. I also work alongside Dr. Ryan. Dr. Ryan treats adults so that I don't have to because I love treating children. It's much more fun for me. And having said that, though, he is very I'll put this, hopefully you can see that he is lots of fun. He also calls me up and says, Dr. Libby, I've set up something for us to go to the zoo and check the dinosaurs' teeth. So that's the kind of dentist that he is, but he's also very accomplished and is very good at delivering quality healthcare with a caring side as well. He also does some treatments which might help with enamel defects in adults, such as icon treatment, which we'll talk about a bit later. Most of children who have enamel defects, they probably have them running in the family. And so it could be you as the parent also have an enamel defect, but you've never known that you can do something about it. So that's another area that if you have any questions about, we can help you with. This is where I work in Edinburgh. I'll just give you a quick tour of the clinic. It's set up in a very unique way to make children feel welcome, to make them feel excited about coming in. We want to make everybody feel at home, like they're part of a family. So we have a lovely reception area, which is nice and bright. We have lots of caffeine available for the staff and for the patients. We have a lovely fish tank with Real Finding Nemo. And just down the corridor, you'll see we've got a unique toothbrushing disco selfie room for all those families who are coming in quite rushed and haven't managed to brush or have had a snack on the way. They can come in and brush their teeth and then take a selfie. But through here is where the magic starts because I have a lovely sky studio, which is set up specifically for children. It's especially good for younger children and children with special needs. I have a lovely tree, which has all the pictures of all the children I see. I've got lots of choices for sunglasses for them. We have superhero capes for them to wear while they're having their treatments. We have a sink to do some toothbrushing in and our lovely marshmallow bench there for the younger children to lie on to have their teeth examined. We also have a treasure chest because children these days are not motivated by stickers. So I give them prizes, which they appreciate and hold a little more sentimental value to. In my singing studio where I get happy and sing because I see teeth, I have a lovely cinema chair is what I call it, cinema seat. And it means that my patients can lie back and relax. And we have a TV up on the ceiling, which can help facilitate our treatments and deliver them a lot more comfortably for children because TV is a great distraction and we need to utilize all the tools that we have. Going forwards, I just want to say that I don't have any financial interest in any of the companies or products that I mentioned in the webinar and toothpaste, anything that you ask me about. I do not hold any financial interests. If I like a product and I use it and I read the research about it and find it's useful and would be of benefit to my patients, I recommend it. Otherwise, I don't. As you will be aware, this doesn't replace a dental assessment. This is just general advice about enamel defects in general, you do need to have your child looked after by a trained dental professional. That's very important. And I only give, I'm responsible for the advice I give out to patients who are under my care. And please do not record the webinar. We will be recording it and it will be shared afterwards for you to look back on. Thank you. So the first thing I want to do is I want to ask you guys, how do you feel about your child's oral health? Are you confident about looking after your child's oral health? Just look at the chart that we have up of the ducks. So if number 1 is you, it means that you feel super duper confident about looking after your child's oral health. I would hope, if your child is my patient and I have given you this advice, that you would be answering number 1. Maybe some people will be in the middle, but the point of this webinar today is to bring you up from a higher number up to the lower numbers, which indicate that you're more confident. So hopefully you'll all be feeling like a number 1 or a number 2 at the end of this webinar. I'll just leave it open for everybody to give me an answer and we'll see where we're at. It's good to see that lots of people are super confident about their child's oral health. That's brilliant, because what I say is you can always level up. Even if you're feeling super, super good, you might come out finding out something new, which might help you going forwards to make it even better. So we're going to level up, everyone. We're going to make sure that we get even better at looking after our children's teeth. So I'm going to close that in 5 more seconds. 3, 2, 1. Okay. So lots of people answered number 1, about 36%. Lots of people said 2, 3. So we've got a mixture of answers, and some people don't feel confident at all. But hopefully by the end of this webinar, you will be feeling super duper confident about looking after your child's teeth. So what are enamel defects? Enamel defects are when the top layer of the teeth or enamel is not formed correctly. Usually it presents in 2 ways: molar incisor hypomineralization and amelogenesis imperfecta. These are the 2 main enamel defects which I'm going to talk about tonight because they're the most common. Molar incisor hypomineralization, or we're going to keep calling it MIH, otherwise I'll get super tired tonight, but it is hypomineralization of the systemic origin presenting as demarcated qualitative defects of enamel in 1 to 4 first permanent molars, and it is frequently associated with affected incisors. And recent research is showing that we also see a pattern where the second primary molar is also affected. So that's something that we look out for in the baby teeth. So if the baby second molar is affected, we know that that is a warning sign that something might be going on with the first permanent molar. And the reason for that is that both of these teeth are all sort of formed around the same time. How prevalent is it? There's some people that say lower numbers, like 2%. Some people say 40%, but we don't know if it's being underdiagnosed or overdiagnosed. We're not sure yet. It can affect people in varying ways. Some people are severely affected, some people are mildly affected, some might go undiagnosed, other people might go diagnosed as caries rather than molar incisor hypomineralization. It's very difficult to say. For me, I know that when somebody comes to me and says that they have a problem with their back adult tooth in their child who is 6 or 7 or 8 years old, and they've never had any problems with their baby teeth, I put that up as a flag that something is wrong with that adult tooth, because how did that child make it for years without any problems in their baby teeth, which are smaller and easier to break down, but they've turned up with this really nice big adult tooth that has a bulk of enamel on it, and already it has problems after it's come through, because they come through around the age of 6. So sometimes they might have also had some problems, as we mentioned, in the second baby molar. So those are the 2 flags that for me would indicate this is probably MIH, and that's why we've got problems in these molars. How did it happen? Why does it happen? Why do we get MIH? It could be due to an acute or chronic illness of the mother or child during pregnancy or the first period in their life. It could be due to environmental pollutants. It could be possibly genetic. Nobody actually knows what the exact reason is. We know that it's affected by birth weight, possibly vitamin D, metabolic disorders, childhood diseases, complications at birth, but sometimes some people can tick those boxes and other times people don't tick any boxes and they still have it. The bottom line is we don't really need to know why it's happened, although it would be nice, but we do need to collect more data around that. But when it comes down to it, what's important is looking at these teeth and looking at how we can treat them and how we can help the child. When we're diagnosing MIH, we look for creamy white opacities. So this is a creamy white opacity. Even down here on this bottom tooth on the left, you'll see there's a creamy white opacity. Sometimes it's difficult to see these because they don't show up when the tooth is wet. So if they are very faint or just very mild, they won't be visible unless the tooth is dry, which never happens unless you're a dentist and you spray the tooth with an air syringe to see what it looks like when it's dry, or if you use something like a cotton wool roll to dry it, which is what I do when I meet any child. I dry their teeth to see and look out for any of these defects which are not very visible. They'll be the milder side, but they are warning signs, and it means we have to do something extra to look after these teeth. We look at different colors. Of course, there's yellow brown opacities. There's times when the tooth will come through like this one on the bottom right, and all of a sudden it will just disintegrate. So it will just disintegrate before your eyes. It's called post-eruptive enamel breakdown. As soon as that enamel comes through and it's in the oral cavity, in the mouth, all of a sudden it just starts to crumble. And, you know, as a parent, that's quite scary because you're looking in your child's mouth one day and they've got a tooth. You're looking in it the next day and half of it's gone. So just be very proactive in looking inside your children's mouths and knowing what's going on. And if anything does happen, getting to a dentist as soon as possible. Atypical caries just means that it doesn't follow, so that the cavities or the caries don't follow the typical pattern that they would. Usually the caries would be in the areas where all the plaque will collect, which is in the grooves of the molars, which is at the gum line of the incisors. But if the caries is happening in other areas which are easy to keep clean, then we know that there's something wrong with that enamel, it's defective. We sometimes have one molar which is affected, sometimes we have all of them, sometimes all of them are mild, all of them are severe, one is severe, 3 are mild. It's really hard, there's no pattern, everybody is different. We just take each tooth as it is and make sure that we deal with it appropriately. Sometimes we have the incisors involved as well, just because they are formed around the same time as those first permanent molars, but they are affected a little bit differently. The incisors don't tend to have post-eruptive breakdown, which is great, but they do sometimes have whitish demarcations or even brownish opacities. So they'll have some kind of discoloration. And in all of these things, we might have some sensitivity, which we'll talk about in a while. And the other key component is that the other teeth are not affected. And what do we mean by the other teeth? We mean like the other, the canines and the premolars and the second adult molar, they are not affected because they were formed at a different time than those teeth which are affected. Sometimes they have difficulty erupting as well, just because they're not the right quality of enamel on the surface. So sometimes it's mistaken for other things like fluorosis, which I'll touch on a little bit later. Hypoplasia is when just the teeth are not formed correctly in a different way, and amelogenesis imperfecta, which we're going to talk about. And sometimes it might just be a lone white spot lesion. Sometimes it can be traumatic hypomineralization, which is when you've had a bump to the baby teeth, they've bumped into the adult teeth sitting underneath it, and it causes an area which is not mineralized correctly. Amelogenesis imperfecta has different types. There's a hypoplastic type, which is where we have good enamel, but the way it's laid out on the teeth is not the right way. So it might be bumpy and pitted, like on the top right side over here. This is an example of hypoplastic amelogenesis imperfecta. The hypoplastic type is strong, so the enamel itself is strong, it's just shaped wrong. So we can get the pitting, or we could even get smaller type of teeth, but that is the type that is affecting the quantity of the enamel, not the quality. The other type is the hypomineralized type, which is a quality defect. So it's actually the quality of the enamel isn't very good. It's not very strong. It can look a bit yellow, or it can have a slightly white capped appearance. We say it's a bit like snow peaks on mountains. And also we can have a combination of all of these types as well. Melogenesis imperfecta affects all of the teeth, and it's genetic in component, and the way to confirm it is by doing a genetic test, although not many people go out of the way to do it, because not many people feel that that's what you need to do, because it doesn't really make a difference to what you're doing, because you're treating the teeth as they are. It doesn't really make a difference if you know or don't know why it's happened. I'm going to talk about fluorosis very quickly, because I don't think it's very common in the UK, which is why I've put a picture of a horse dressed as a zebra, because the saying is, what's the saying, Dr. Ryan? Let's see if he's awake still.
Yes, I'm here. Your husband taught me this saying a many a time. If you hear hooves in London, it's not a zebra, it's a horse.
Yes.
Something like that.
Yeah. So if you hear horse hoofbeats, think horse, not zebra. If you hear hoofbeats, think horse, not zebra, because here in the UK, we don't have many zebras, but we do have lots of horses. We don't have fluorosis very commonly in the UK, and the reason is we don't have many fluoridated water sources, but also we have controlled sort of fluoride products in the market, and we have a general good kind of level of education of how much fluoride to give our kids. So generally speaking, fluorosis doesn't happen, but it can be misdiagnosed. So lots of people say, this is fluorosis. How do we know the difference? If you've got fluorosis, you'll have the white flecks on the teeth, but they will be super strong flecks because they're full of fluoride. They are there, but they do not fall apart. They do not get caries on them. They're very caries resistant, so they will not get cavities. So fluorosis isn't very common in the UK. Sometimes we see it from families who are coming from different countries which do have fluoridation in the water and have the additional fluoride source. But here in the UK, I would probably safely say that it's not going to be fluorosis. It's more likely to be MIH or AI. Moving on, what does this mean? So actually what it is, how it happened, is important sometimes for us to know. What's important actually to know is that it's something out of your control. It's not something that you choose to have or something that you can control, but it's something that's just happened and you have to accept it. What does it mean? I want you to think of your teeth like skin. Everybody has different skin. You wouldn't beat yourself up that your child has the type of skin that burns easily, would you? Because it's something that's totally out of your control, and that's what it is when it comes to our teeth that are hypomineralized. The hypomineralization is nobody's fault, it's just the way the teeth are. But what does it mean if we're thinking about the teeth being like skin? It means we need to care for them exactly like we care for our skin. If you look at the look at the health messages towards skin, what do they say? They say, seek less sun, put on shades, put on lotion, cover up with your clothes, wear a hat, check your skin for any problems. So this is the same concept we're going to take and we're going to implement it on our teeth. The first part is seeking less sun. So seeking less sun for your skin is equal to seeking less acid and sugar for your teeth. When you know that your child has an enamel defect, it means that a small amount of acid or a small amount of sugar will have a different effect on your child's teeth in comparison to somebody who does not have an enamel defect. Is it fair? Probably not, but that's just the way it is. So we just need to make sure that we adapt to suit that, to give our child the best possible outcome. So seeking less sun is seeking less acids and sugar. And that's all about frequency, exposure, the types of sugars that they're having, which we're going to talk about in more detail. But first we need to understand why acids and sugar affect our teeth. When we have any acids, which can be in the form of our food and drink, or we have any sugars which will cause acidity in the mouth, what happens is that acidity pulls out minerals from our teeth. So you can see the tooth up on the left-hand side with the orange, and it's in the state of demineralization. That is when minerals are pulled out of the tooth because there is acidity around it. What happens is every time our tooth sits in the saliva, which has calcium and phosphate minerals, the minerals go back into the tooth and remineralize it. This is a balance that we have to strike every single time we eat and drink. That's what's going on. Calcium and phosphate coming out when you've finished eating and the acidity has gone away from your mouth, the calcium and phosphate go back into your tooth. If the tooth is already weaker, then that calcium and phosphate coming out can affect it negatively if we're not doing extra things to remineralize, to put back in the calcium and phosphate into our tooth. Now, where does fluoride come into this? Fluoride comes into this because when we have demineralized tooth enamel, fluoride can remineralize that tooth enamel, and it forms a new crystal called a fluorapatite crystal. And fluorapatite crystals are actually stronger than the original hydroxyapatite crystals that we have on our teeth. So actually, the fluoride will cause us to have a stronger tooth surface if it's used enough and in a way that's controlled, but it will always need to be outweighing the demineralization. So what I say to parents and children is when you have anything that's acidic or sweet, all you're doing is you're undoing the hard work you've been doing to put minerals back into your teeth through brushing and through rinsing your mouth out after eating, doing all the things that we're going to talk about to keep remineralizing your enamel. If you're having acidic drinks, if you're having foods with sugars in them, you're just undoing that hard work. So every time you eat something, you have a sugar intake. This is Stefan's curve on the left. It goes from a neutral pH, it goes all the way down below 5.5, which is where our plaque is. And in this area for around about half an hour, we have some demineralization of the tooth where the minerals are being taken out. How does that matter? Well, every time we have our teeth being demineralized, we will end up with the first stage of tooth decay, which is a white spot. If the demineralization continues to outweigh the remineralization, we end up with enamel decay, followed by dentine decay, followed by nerve involvement of the pulp and abscesses, and eventually we'll lose the tooth, which is definitely nobody's end goal. So our job is to counteract the demineralization by doing lots of remineralization, but also cutting down the exposures to sugar and acid. And when we're talking about cutting down the exposures, it's not necessarily about the amount that you're having, but it's more about the frequency, because we want to cut down those half-hour windows where our teeth are at risk. So it's all about timing, how often you're having these things, how frequently. But as a parent, I get super annoyed when people tell me to do something and I don't understand it fully. So when I say to you, are you having too much sugar? Do you know how much is too much? I don't think anybody does. So how do we know if we're giving our child too much sugar? Well, we need to actually teach them, and we need to teach ourselves how much is too much so that we know if we're having too much. So the next part we're going to talk about is how to measure how much sugar you're having in a day on average. So I like to take it as an average. My average that I've chosen is 3 teaspoons a day. The WHO recommends that you have less than 10% of your total energy intake as sugar, and they refer to free sugars as being damaging to our health and our teeth. And these include sugars which are naturally in foods like honey, syrups, fruit juices, and fruit juice concentrates. So it's not just chocolates and ice cream we're talking about all these other things as well, which are natural sugars. Because I say to kids, the sugar bugs, which we're going to talk about a little later, do not care where the sugar came from. They're still going to eat it, and they're still going to do their poo, which is the plaque. We'll talk about that later as well. But that is why we need to make sure that we are mindful of how much sugar we're having. 3 teaspoons a day is a great measure for you to refer to, but you have to also understand how to know how much sugar is in things, which we're going to talk about next. So I've given you here the guidelines from the WHO, but also the guidelines from the NHS of how much sugar they should have in a day. But please remember that's not how much they should have, sorry, it's they should have no more than, okay? So you're not aiming to get this sugar into them, quite the opposite. If you get up to that, you're in a super danger zone. Try and avoid reaching that target. But like I said, I like to take it as an average over the week. So for my own kids, what I say to them is you have 3 teaspoons a day. You can save them up and have them at the weekend in 1 go or in 2 goes. But the main thing is we're not having those 3 teaspoons spread out over 1 teaspoon at 3 different times during the day, because each one of those times will be a half-hour exposure to demineralization, which we don't want. So trying to condense it into less often is much more beneficial for our oral health. So I'm just going to ask you guys a quick question, another poll, just to see, did you know, oh, actually, wait, we'll do the next part and then we'll do the poll. So let's move on to the packets. I teach children how to read packets, how to read labels, because what I want is for them to be aware of the sugars that they're having. If I tell you to moderate your child, all you're going to do is say yes and no, and they are not going to learn anything. I want you to take your child out when you go shopping, and if they ask you for something, I want you to turn over the label with them. I want you to read the label. I want you to tell them how many teaspoons of sugar is in that product which you're about to buy. Tell them that they have 3 teaspoons per day. It's like their pocket money. They're going to save it up and get something sugary. Is this what they want to spend their sugar on? You'll find that children, when you give them that choice, become much more selective about the times that they're having sugar and what they're having as their sugar. And knowing how to read a label gives you control of choosing products which have less sugar in them. So I always do, on my virtual calls with my patients, we do a little bit of online shopping. Part of that shopping is to learn how to read a label and to give the example of why when you are looking at 2 products which are the same content, you can find really varying numbers of teaspoons of sugar in them. So we're going to look at Nutella first together. So this is Nutella. Of course, I think everybody knows this, this graphic here of what's inside Nutella. But what does it mean, like when you're feeding it to your child? We said 3 teaspoons on average a day. Let's look at what they say. They say a portion is 15 grams, absolute liars. We're going to cross that out because I've measured out 15 grams. It's just like a lick. It's not a full teaspoon. It's hardly any. My kids would eat much, much more than that if I gave them Nutella, which I do sometimes, by the way. But in 100 grams, and I've measured out 100 grams, it's about 2 big piled up spoons of Nutella. So I think that maybe a good portion is probably 1 big spoon or 2 big spoons. Some people have 2 big spoons. So let's look at how much sugar is in there. When we go down to the line that says sugars down here and we read how much sugar is in it, it says 56.3, which means absolutely nothing to anybody, okay, because we are not scales. But I know that 4 grams of sugar equals 1 teaspoon, okay? This is what I want you to learn from this slide. 4 grams of sugar equals 1 teaspoon. If you know that, then you can easily go to the shops, read how much is in grams, divide it by 4, and you'll know how many teaspoons. And that's a very visual way of teaching your children how much sugar is in something. So in 56.3 grams, if you divide it by 4, it comes to just over 14 teaspoons. So now we know that in 2 big spoons of Nutella, there are over 14 teaspoons of sugar. If you say to your child, there's 56 grams of sugar in that, very different to you saying there's 14 teaspoons of sugar in that. Now, they said in a portion there's 15 grams, which would mean that if you had the portion that they're mentioning, you'd have just over 2 teaspoons, because 8.4 divided by 2 is just over 2. Divided by 4 is just over 2. So they would have 2 teaspoons. However, that's a lie, because that isn't how much we have. We have much, much more. So this is a very good way of children understanding how much sugar is in things, but it's also teaching them the mindset of why you're making certain decisions. So when you go out shopping, if they ask you, why can't we have this? Instead of you having to explain, instead of you having to just say, no, you can't have it, you can actually explain to them. And that means that when they go out and they turn over labels when they're older and they make decisions in the shops, they will be making good decisions based on their education and not just based on, my mum lets me have this, my dad doesn't let me have that, basing their decisions on that. Why do you need to read the labels? Another reason why you need to read the labels is because you can find alternatives. So an alternative product to Nutella is Jim Jams, which is a hazelnut chocolate spread as well. It tastes exactly the same as Nutella. It's what I buy in for my children if we have a chocolate spread. But when you look at how many sugars are in this, you'll notice firstly, they just tell you all about 100 grams. They don't tell you about any less than that. They don't try and trick you to say that 15 grams is a portion. And in 100 grams, there's just over 2 teaspoons of sugar, which is a huge difference from 14 teaspoons of sugar. So definitely worthwhile reading the labels and educating your child on how to read the labels so they feel in control, so that you're not constantly fighting with your children about this. Okay. So we're just going to move on now to fruits and juices. Everybody asks me, but what about fruit? Fruit is acidic. Can we eat apples and oranges and pears and bananas and grapes? The answer is yes, you can eat them. I don't want you to drink them. If you eat them, when you start to chew them in your mouth, that's when the enzymes will start to break them down into sugars and acids. And they've also got lots of fiber in them. They're also going to be rubbing against your teeth, doing some cleaning as well. And then you're going to swallow them. And you probably can't eat too much of them if you're eating them in the whole form. So if I gave you 5 or 6 apples, it would take you a long time to eat through them. But also when you're eating them, you're getting the sugar of all of those apples, which is not likely. You're not going to sit there and crunch through 5 or 6 apples. If you have them as a juice, you're definitely going to have more than 5 or 6 apples in the form of sugar. So when you have a fruit juice, it can have 5.5 teaspoons of sugar, and that's in a small child-sized sort of carton. So that's a lot of sugar to have all at once. As soon as it hits your teeth, it's already acidic, it's already sugary, and it's directly in contact with all surfaces of your teeth. If you're going to have fruit, rinse your mouth after with some water, and just, that's fine by me, tooth-wise. If you're going to have a juice, you need to be much more careful. You need to use a straw to stop it from touching your teeth too much. You need to rinse your mouth out after eating it, drinking it. And you also need to make sure that you do not brush your teeth after having an acidic drink for at least half an hour. Now, acidic drinks, you're probably thinking, is it just like Iron Brew and cola and Pepsi? No, it's everything. It is diluting juice, it is fruit juice, it is smoothies. Anything that is not plain water and plain cow's milk is going to be acidic on your teeth. So we need to make sure that we are avoiding them. Natural sugars, still damaging to our teeth, okay? So they're better for our body, not better for our teeth. So if we're having them, we need to be careful and do something to protect ourselves. I'm going to ask you quickly, now we're going to do our little poll again. So did you know how much sugar intake should be in teaspoons? So were you aware of that, or is this new information? So I hope the people who know me and have had a virtual call with me are answering yes, because that's what I would expect at this point, please. I hope everyone's listening to me. I like using teaspoons and I like having numbers because it gives you a measurable thing to refer to. So when your child says, why can't I have this, sweetie? I really want it. You say, well, you've had, you know, like 4 teaspoons of sugar this week. Yesterday, you've had like 10 teaspoons yesterday because we had a treat. You can't really have a treat as well today because we've had that much sugar. So it's kind of like giving you a measure to fall back on and an answer for your children. So Ryan, are we getting on okay? I can see that somebody's raising their hand. If you have any questions, just pop them in the chat and we'll talk about them a little bit at the end. Okay, perfect. So far, lots of people didn't know how much sugar should be, how many teaspoons of sugar. So I will just share the result in maybe a few more seconds. Most people have participated now. So we'll give it 5 more seconds. Okay, here we go. We're going to end the poll. And you can see that most of you didn't know a measure. Honestly, having a measure really, really changes the way that you're speaking to your children about it. So I'll share those results for you. You can have a look. Great. So I hope everybody's still awake. I'm feeling really energized. I'm really excited to keep sharing this information with you. Let's keep going, guys. I'll just move this one out of the way. Here we go. So what are my secret tips? Because I'm a parent as well. I have real life children, not hypothetical children. I have actual real life children. And I like to teach you little tips and tricks. Anything that you don't want them to have often, just don't have it in the house. It's just so much easier. It's so much less stressful. It means that you don't have to keep giving answers, excuses. You don't have to keep track of things. It's just not there. Out of sight, out of mind, but also it leads to more positive interactions. When your child comes to you and says, can I have this sweet, or can I have an ice cream, or can I have a drink of juice? If you say, no, you can't have it, usually the answer will be back at you, why not? Can I have it later? Can I have it tomorrow? You said I could have it yesterday. It's not fair. My brother, sister, dad had some and I didn't. That's not fair. So it's all about all of these interactions which are really, really negative and make you come across as the bad parent. Instead of those interactions, what you will have is positive interaction, because you will say, sorry, we don't have any, but next time we go out, we can get some at the weekend when we're having our treat. So you can go out of your way to give them the opportunity to choose something, and that should make them feel more empowered, and as a result less negativity in the house, which, you know, who needs more negativity these days? Not me, definitely. And the other tip I have is buying in things less frequently. So the things that you wouldn't necessarily have when you go out at the weekend. So we're not talking about like juices and ice creams, we're talking about like chocolate spreads or honey or jam. Just buy them in less frequently. So buy them in when they run out. Don't run out and buy another pack straight away. Wait for a couple of weeks, let them miss it, and then buy it in again. That way you've got it less often and they're less likely to want to nag you about it as well. So that's another way of moderating. So we've talked about keeping ourselves out of the sun. We're seeking less sun. That's by avoiding acids and avoiding sugars. We've talked a little bit about how to control that around children in an empowering way so that it's less stressful for you. And remember, you might come across as being too strict with your child, but you have to remember that your child's enamel is special and it needs this extra care. Moving on, we need to cover up the teeth. So here it says, put on the sunshades, cover up with clothes, wear a wide brim hat. What does that mean for our teeth? That means that the areas that are at risk, we need to cover them up. How do we cover them up? We cover them up with something called a sealant, a fissure sealant. So fissure sealants come in lots of different forms. There are ones that go directly onto the tooth surface, which are a glass ionomer cement, and you don't need to wash and dry the tooth. There are others that need you to wash and dry the tooth, and they are resin-based fissure sealants. I do ones in colors. I also do ones in plain white for the resin sealants. And the reason why I like the colored ones is that sometimes that can be the difference between a child cooperating and not cooperating, because they get excited about the color of their tooth. Also, it's really nice because you can see it when it's wearing away. Sealants are not permanent. When you put them on, they need to be maintained. They need to be checked, because a sealant which is sitting there on the surface of the tooth, which is leaking, is going to be worse than having a sealant that is not there at all. What we want to make sure is that the grooves of the tooth are filled up with the sealant. So you can see her on the bottom left. I'll just get my wee pencil out. On the bottom left here, this tooth, can you see how it has some discoloration on the tooth surface? Those areas had become demineralized. They were starting to darken as well over here. So we just simply put this sealant on, and you can see it's gone into the grooves of the tooth, which has made all that tooth surface much more cleansable. No food can get caught in it, and we've essentially starved the bacteria of any oxygen, so that defect or that enamel breakdown cannot progress. So this is why we use a sealant. You can see here, this child had quite a deep pit in their tooth, and the mum was super concerned. And every time we put in a sealant, it just wore away very quickly, which is why we tried to move on to our resin sealants. And for this young child who was under 3 at the time, we managed to get her to sit still for those 2 minutes and to wash and dry the tooth, just because she really wanted a pink tooth. So it is the difference sometimes when it comes to cooperation, and sometimes we have to beg them to cooperate, and other times we don't. But in general, we just go by what they are feeling like on the day. So moving forward, I've lost my mouse. It's gone walkabouts. Let me see if I can find it again, guys. Ryan, how are we doing on questions? Should we do a few questions now while I'm looking for my mouse?
Sure, yeah. Can you hear me okay?
Yes, I can hear you.
So we've had quite a few questions actually. I'm trying my best to field them, but I'm not wanting to answer them because I think they would be helpful for the group. So there was one question more so about the family history of enamel hyperplasia, where I've got a 6-year-old and a 4-year-old girl with it, and they want to know if the adult teeth would be fine. I think you maybe touched on that at the beginning of your talk. So is someone that has enamel hyperplasia as a 6 or 4-year-old going to have hypoplastic adult teeth?
It is likely, and it means that we have to be more vigilant in monitoring the child as they're growing. We see which teeth are affected. We see the pattern of how it's affected. One of the signs which we can look out for on the adult teeth when they come through, if they have any defects, sometimes if it's on only the front surface of the front teeth, that can mean that it is only in the adult teeth, only in molar incisor hypomineralization, which is the front 4 incisors and the 4 back molars. However, if they are, if the markings are also on the back surface of the tooth, it means that it's probably going to affect all of the teeth. So there are a few little minute kind of signs which a specialist can look out for, and will be able to give you a better idea, but you would need to have like a full examination to be able to give an opinion on that. But also you never really know until they come through, because they could all be affected, but affected really mildly in a way that doesn't affect the child at all, or they could be affected severely. It's very difficult to tell.
Thank you. I'll try and keep it in the theme of, you know, what you've just been chatting about with regards to diet. Someone has asked, what about sugar-free fizzy drinks or sparkling water or sugar-free flavoured water? Are they okay?
Great question. Sugar-free doesn't mean acid-free. So yes, it doesn't have sugar in, but it still has acid in. So it's still really damaging to our teeth. However, sparkling water is not acidic. So I have the litmus paper that you use in your labs when you're at school, and everybody says, oh, let's test the pH of this, the pH of that. I've tested the pH of things. I've also read scientific papers talking about the acidity of certain drinks. Orange juice and touch of fruit water are both acidic. Iron brew, diluting juice, both acidic. Anything that isn't plain water, plain cow's milk, is acidic for our teeth. And if you test sparkling water, it isn't acidic. So I would go with plain water, sparkling water, without adding anything to it, and cow's milk, as I said. The reason why I say cow's milk specifically and not milk is because now lots of people are having milk substitutes like almond milk, soy milk, rice milk, oat milk, coconut milk. All of these milks are great. However, they have natural sugars in them. So even the ones that don't have any added sugar to them, the natural sugars that are in them can be fermented in the mouth. Therefore, they are damaging to the teeth. Cow's milk is the only milk that doesn't have sugars which can be fermented in the mouth. However, even overnight, still dangerous for our teeth, because I don't know if you've tried it, Ryan, but try having a bit of milk in your mouth, and over time it will go acidic. So holding it in your mouth will make it acidic, which is what happens overnight when we're having any drink in our mouth. It doesn't wash away quickly from our teeth because we're not talking like I am now, and we're not chewing and eating, so it doesn't get washed away by the saliva. Okay.
Thank you.
Thank you. Right, we're going to move on to other protective factors. So the other protective factor, which I love to use for teeth, is tooth mousse. The reason why I love tooth mousse is because it's an added protection. It's sunscreen for our teeth. If we know that we are being exposed to more sugars and more acids, it means that we need to have more protection. The form of protection for teeth, and especially for hypomineralized teeth or teeth with enamel defects, is tooth mousse. It has calcium and phosphate. Remember when we go back to that diagram about the demineralization and remineralization, something which remineralizes is calcium and phosphate. It's found in our saliva. This is like a turbocharged saliva. It's like making sure that your teeth are not sitting in acid. So when I go on holiday, you can see these are the 2 holidays I've had this year. Each one was 4 days, very quick. But one, at the first holiday, I took my Tutti Frutti tooth mousse. Anytime we were at the pool, we were having our sun cream on, we'd put a bit of sun cream for our teeth, which is tooth mousse. And the same goes for the strawberry one. So we took it around town, had it in my bag. Yes, my kids were having fizzy drinks. Yes, I was having fizzy drinks. We're having more ice creams than usual. That's why we're adding in tooth mousse. Tooth mousse doesn't replace brushing. It is an added protective factor on top of brushing. When it comes to our hypomineralized teeth, or teeth which have sensitivity, because what happens is hypomineralized teeth tend to be very sensitive to the cold, the tooth mousse can help to decrease that sensitivity and protect those teeth. And I have found that the patients I have who are using it quite consistently are getting shinier, easier to care for teeth, because they are constantly being remineralized by the tooth mousse, in addition to the brushing, in addition to the enhanced prevention, which I provide them with. So I've seen the quality of their enamel improve vastly. This is a little information leaflet about tooth mousse, what it is, what it does, and how to use it. If anybody has any further questions or wants to receive this leaflet, you can let me know. I'll also give you some more information at the end about tooth mousse as well. So we've talked about keeping out of the sun. We've talked about adding protection. We've also talked about covering up with sealants. Now we need to talk about checking. You need to check your teeth regularly. It is not possible for you as a parent to be everything. You are not everything. You're not a dentist, unless you are a dentist, of course. I apologize if you are. Some people are dentists. I know that some dentists bring their children to see me, which is a very huge compliment, but that is because a thorough check of a child is really, really difficult. To get a child to sit still, to dry the surfaces of their teeth, and to get good x-rays if you need them is really important, because that is the only way that you're going to spot problems early on and address them before they become bigger. When you have a child who has an enamel defect, it becomes even more important that you see a dentist more regularly. So it wouldn't be every 6 months, it would be every 3 months, because a lot can change in 3 months. A lot can change during short periods of time. What I tend to find with the parents who come to me is that they have had a problem which escalates really, really quickly. So a matter of a couple of months rather than, 6 to 12 months. We're talking about a couple of months, things can change. So having your teeth checked well is very, very important. Now, oral hygiene is it's important for everybody, but it's even more important for children with enamel defects. And the problem is it's also more challenging. It's more challenging for a few reasons. When we're talking about hypomineralized teeth, they are more porous, which I like to give an example of a clay pot. They are like a clay pot that has no glaze on it. When you have a clay pot with no glaze and you put anything on it, it is absorbed straight into the surface and it's difficult to remove. That's what happens with our hypomineralized teeth. The plaque sticks to it really well. Stains from foods and drinks stick to it really well, and it's harder to brush. It's harder to brush because it's harder to remove from a porous surface than it is to remove from a really nice, smooth, shiny surface. And that's why we need to take extra care to do our oral hygiene. And that's where things like disclosing tablets come into play. So disclosing tablets will show you where the plaque is on the teeth, and it will help you to guide your child with their brushing or with your brushing of their teeth. So yes, oral hygiene is more challenging, but it is more important. It's also more challenging because the teeth might be more sensitive, so they might might not feel comfortable when you're brushing. Again, that is where our tooth mousse comes in. Using it regularly will decrease sensitivity, which enables you to clean them more thoroughly because they will feel more comfortable when you're cleaning them. And simple things sometimes like using warm water when you're brushing instead of cold water can make a difference for children with sensitivity. So I like to introduce children to my sugar bug poo story because I feel it's a really nice visual way of them understanding why they need to brush their teeth. And once children understand why they need to brush their teeth, they are much more likely to be cooperative and they are more motivated to brush their teeth. And it just makes life a lot easier. And it's very visual, it's very simple. Do you want poo in your mouth? Absolutely no. Put your hand up if you don't want poo on your mouth, because that's what I ask children when they come in to see me. I say, do you want poo in your mouth? Usually the answer is no. So let's see, does anybody want poo in their mouth in here? Absolutely not. Nobody wants poo in their mouth. So sugar bug poo is essentially plaque. Sugar bugs are the bacteria in our mouth. Every time you eat and drink, that bacteria also eats and drinks with you. It does a poo on your teeth, which is the plaque. That's the excrement from the bacteria, and that is what makes our teeth go soft. When our teeth are already soft from sugars and acids, it means that the sugar bugs have an even easier time of digging a hole in your child's tooth or in your tooth. And that's why we need to make sure that we're removing food from our teeth so that they don't have anything to eat. We need to make sure we're removing the plaque from our teeth so that it doesn't damage the enamel and make it easy for the sugar bugs to dig their holes. And the way to do this, because the sugar bugs are camouflaged, is to use disclosing tablets. Disclosing tablets are going to be your best friend as a parent because they are the only way that you can see whether or not you are brushing your child's teeth properly, and they are the only way you can show your child why you still need to help them to brush properly when they're at that in-between stage, which is around the age of 7 or 8, because children cannot brush their own teeth properly unless they have the correct manual dexterity. And manual dexterity is measured by things like tying their own shoelaces, writing neatly with their handwriting. So if they can do both of those things, they have the right manual dexterity to be able to do it. But then you're going to use the disclosing tablets in a different way, which is to guide them how to brush better. They brush their teeth. You give them a disclosing tablet, it shows up all the areas which have not been brushed properly. Oh no, look at all the poo that's still on your teeth. Let's go back and brush them. If you're still at the stage where you're helping them, it will help them to be on board with you helping them. And if they're at the stage where they are brushing on their own, it will guide them on as to how to make their brushing better. And when they are stroppy teenagers, you know they know how to brush. They lie to you about brushing. My teenagers do it sometimes. You can just say to them, well, chew a disclosing tablet and then we'll know for sure whether or not you have brushed well. So it's a very clear-cut way of getting a clearer picture. And I say to people, it's an educational tool, it's fun, it's interesting, it keeps them engaged. For me, I use them on myself sometimes to make sure that I'm brushing well. So it's not a punishment, it's actually a really good learning tool. So that is why we use disclosing tablets. And this is the way that I motivate my patients to use them. And I want to remind you all that positivity is infectious. I have lots of patients who send me messages, videos, pictures of them doing things, thinking of me, saying, you know, we did this because you told us to, we're reading our sugar bug story, we're brushing all the sugar bugs away from all the toys at home. And positivity is really infectious for children. So if you're always giving a positive outlook on brushing, that's how they're going to feel about it, about oral hygiene. If they see you're excited about it, they will be excited as well. So don't treat it as a chore, treat it as a challenge and something fun and something exciting, and that's how they're going to feel. Now, I want you to put your hands up if your children floss their teeth, okay? So if your children floss their teeth, please just pop your hand up for me. Okay. I'm hoping, again, all the people whose children come to see me, please say that your children are flossing. They tell me they are. I can see their gums are healthy, but we'll see, right? So we've got about 11, 12. It's going up and down. So quite a few people have children who floss their teeth, which is fantastic. Flossing is really important. So flossing is not something that we only do as adults. We have teeth when we're children. So why don't we floss them? Of course we need to floss them. Everybody needs to floss their teeth regardless of age. If your teeth are sitting next to one another, they require to be flossed, because in between your teeth, if your toothbrush cannot reach in between them, then that is a place where we're going to get plaque buildup, we're going to get acidity, we're going to get breakdown of tooth structure. So we definitely need to floss. Flossing is excellent because it gives you a visual feedback, again, like the disclosing tablets. When you floss in between a child's tooth, then you can see in between, when you take the string out, you can see on the string the bits of plaque. That reinforces to them that that's why they're doing it. The sugar bug poo is coming out on the string. And I say to children, if you're brave, smell it, because it doesn't smell nice. And then they start to believe you when you say there's poo in their mouth. So flossing gives another visual feedback, another kind of like gratification instantly that you're doing something to clean your teeth, which is excellent. Now, a very good reason to floss your teeth. Can you see, of course, one of the reasons is to get one of my badges, which are cool. But the other reason is this. Can you see this tooth here in the middle? This is actually my youngest daughter's tooth here, okay? And it fell out a few weeks ago. Now, if you look at the side of it, there's a pinprick hole. It's perfectly circular. I'm not drawn it very well, but it was a perfect circle when I looked at it. And the reason is that sometimes we get something called a pinprick defect. So where an area of enamel has just not formed correctly, we have a defect in that area. We don't know why it happens, but the end game is if that defect is not cleaned and not looked after, it will progress to something more. So had I not been flossing my daughter's tooth, that defect would have become a huge cavity and she would have been in pain, she would have had infection. The only way she has dodged that in time for her tooth to fall out is because I was flossing her teeth really well. So really, really important to floss because we do not know what is going on in between the teeth. And if we have an enamel defect, we don't know if a weaker area of enamel is in between the teeth as well. So please, please, please floss. Now, if your child is very young and you feel like their teeth are very spaced out, even better, because what you're going to do is you're going to teach them the habit of having floss in their mouth once a day. So just before they go to bed, at story time, when they're lying in bed, before you start reading your story, just pass the flossers in between their teeth. It will get them used to the sensation of having the floss in their mouth. It'll get them used to the habit. Then as they grow and their teeth come closer together, it will just be their norm. They will not fight you. It will just be what they do. So building that habit of flossing is really, really important, and it pays off later because you will feel like your child's teeth are safe because you know you're keeping them clean in 3D. So I say to kids, remember your teeth are 3D, so we need to look after every single side of them. And yes, I do give out these badges to my floss ambassadors because, again, I empower children. I tell them that they're in charge of the flossing. I want them to make sure that everybody in the household is flossing, and they take it and they run with it. They love it. So moving on. My general approach to oral health and oral hygiene is to empower the children, to give them motivation and control. So we motivate them through visual aids like disclosing tablets and the feedback of flossing. We teach them about reading labels, and we let them be their own advocates. So when they are out in the world and somebody is offering them a sweet or a juice, or they have a choice to make, they're going to think about their teeth and they're going to understand why the decision that they make impacts it. They're also going to know how to protect themselves. So they'll know that if they do have something sweet or acidic, they will rinse their mouth out with some water afterwards. They will know to use things like tooth mousse. So I've had children come into me and giggle, Dr. Libby, today I had a treat. I'll be like, what did you have? Oh, I had a bubble tea. And I'll go, oh my goodness, you had a bubble tea and you came to see me. And the girl who said that said, yes, but I put on tooth mousse. So I was really happy. I didn't mind that she had had a bubble tea and come to see me because she had done something to protect her teeth as well. And that's what it's all about. It's about cancelling out those negative demineralization processes and remineralizing the tooth. So making your child aware of that is much more important than just saying no all the time. When we are talking about other family members who are also part of the team when it comes to looking after our kids' teeth, we need to ask them for support. Don't say, please, don't say, don't give this, they're not allowed this, they can't do this, don't do this, you're not allowed to give them this. That doesn't make them feel like part of the solution. So when you're talking to other family members, ask them for their support, explain to them what's happening with your child's teeth, explain to them the analogy of the skin, and just say to them, if you knew that my child would get sunburnt, would you just put them out in the sun and not put sunscreen on them, or not take care of their skin? It's the same thing with their teeth. We know that their teeth are more likely to get damaged, so please don't expose them to those sugars and acids as much. So positive reinforcement and a family-wide change. All the changes that I have mentioned in terms of diet and oral hygiene should be for the whole family, because it's beneficial for the whole family, and it will make sure that your child doesn't feel left out because they have bad teeth. They have special teeth is what I say, and special teeth need special care, but everybody implementing these things is an added bonus, and that will make your child feel really happy that this is something that you're all doing as a team. Now we've talked about the foundation of looking after our teeth. We've talked about sealants, we've talked about protecting it with tooth mousse, with brushing, with fluoride toothpaste twice a day. We're going to do flossing. We're also going to do something called a fluoride varnish application, which is something that the dentist does when we don't have any enamel defects. We do that twice a year. If your child has any problems or enamel defects, we would do it 4 times a year. That's an enhanced prevention. Painting on that extra fluoride is really important to strengthen the teeth and to keep them safe, alongside all of the other things that you are doing. But let's talk about treatments. What treatments do children with enamel defects need? When we're planning any treatment for the back teeth, which are affected by enamel defect, we need to bear in mind what will happen in the future. So unfortunately, we don't have a crystal ball, but there is a certain degree of planning that we can do alongside an orthodontist, which can help to take into account the future treatment needs and what space requirements there are for your child's jaw and teeth, and it would avoid having healthy tooth extractions in their future orthodontic treatment. So you may notice that there is a tendency for some treatments to require extractions of premolars in their teeth. If your child has already had a problem with their back molars, then it is better to utilize the space from the back molars rather than extracting a healthy tooth further forward in the mouth. And that is something that can be planned between a pediatric dentist and an orthodontist, which is why, as I mentioned at the beginning of the webinar, I'm really lucky to be working alongside my husband, because we can make those decisions on a daily basis and give families the best possible outcomes. So planning is important. The next thing we need to think about is how we address sensitivity, because usually children who have enamel defects have sensitivity. So the way that we're going to address that sensitivity or stop teeth from breaking down further is by sealing them with glass ionomer cement. Glass ionomer cement is a great sealant. I use something called Equia Forte, which is super strong. And the reason why I use it instead of using a resin sealant on most hypomineralized teeth is because it's much more comfortable to place. When you are placing sealants on a tooth which is hypomineralized and it feels sensitive, if you have to put on shampoo, which is the etchant, wash and blow dry, which is what I say to the kids with the water and then the air, doing that on a child who has a hypomineralized tooth which is sensitive can be excruciating pain. I have lots of referrals from general dentists who send the children to me because they have tried to put on Fisher sealants for them. They've tried to do the resin ones because that is the assumed gold standard for our back adult molars. However, when they've attempted to do that, the result has been that the child has become really scared and anxious and will not cooperate for any future treatment. Because bear in mind, these teeth come around the age of 6, so it might be the age of 6 or 7 that we're trying to seal them, and it's still quite a young child. It's difficult to keep the mouth dry at the back where the teeth are sitting. So trying to keep it dry and all these pieces of equipment in their mouth, add in the sensitivity and feeling uncomfortable for them, it's a recipe for disaster. Glass ionomer cement sealants, on the other hand, stick really well to wet teeth, which is perfect. They're easy to place. You don't need to wash and dry beforehand. It's literally, I say to kids, it's like piping icing onto a cake and then patting it with my finger to make it tooth shaped. So that's essentially what I do for children with enamel defects with hypomineralization. We put on GIC sealants and we monitor them regularly every 3 months. I check the sealants to see that it hasn't worn away. I check that it hasn't worn away entirely, or it doesn't need to be topped up, and I make sure that they're always topped up and keeping that top surface smooth and easy to look after and to stop further breakdown. You can seal with resins, but like I said, you need the tooth to be super dry, and you have to be mindful that they might come away a bit quicker than the glass ionomer cements on hypomineralized enamel, because unfortunately, resins are not really designed to stick to hypomineralized enamel. They are designed to stick to boring, normal enamel, which is why, for me, for the most part, I tend to go for the glass ionomer cement sealants. When it comes to having fillings, so I get lots of referrals of children who come to me because the dentist has tried to do a filling and the child is still quite young, it's a back adult tooth, and the child is just not cooperating for it and they're very, very upset, okay? So there are ways to place composites for children, but they do need extra care in preparing them mentally for it and doing the procedures. And sometimes we need to improve the quality of the enamel first, because as I mentioned in the previous slide, the enamel is not really very good to stick to composite resins. Again, a composite is a resin like the resin Fisher sealants. So we need to sometimes improve the quality of the enamel first by using remineralizing agents or using hypochlorite on it. Hypochlorite on it, or by using Icon, which is an infiltrant, to improve the condition of the enamel. And in that way, we can improve the stickiness of the composite to the tooth. However, we can also take a stepwise approach, which is where we remove part of the defect and then close it off. And then if it's very deep, and then we go back when the tooth is more mature, and then we do more caries removal. So there's lots of different things that we need to think about. And sometimes we can use something called biodentine, which can also help to mimic dentine. It literally copies what dentine is like. And it's a very new, it's a new material, which is fantastic at helping us to be able to fix teeth, the back adult molars, which can be quite broken down in young children. However, do we want to do that is the question, because when you're giving local anesthetic to children with MIH, for example, or even AI, the insulation of the pulp is poor. So the pulp is where the nerve is, it's where you get the feeling in your tooth. And if the insulation is poor, it means that trying to get that tooth to be numb is very, very difficult. Sometimes we use inhalation sedation, which is the happy gas or happy air, that can help to maximize the effect of the anesthetic and also help the child to not really feel, not really realize what's going on. So they kind of forget by the end of it what happened. They can tell you if they're feeling uncomfortable, but generally they have a nice floaty feeling from the happy gas, don't really notice what you're doing with the filling and with the anesthetic. But to get a good quality restoration, you need to have good anesthetic and you need to have good cooperation as well. So we need to have these factors in place. And if we don't, it means we're going to have a compromised treatment for that child. We can also use, to help the anesthetic to work better, we can use desensitizing toothpaste or fluoride varnish before we go in and do the filling for the tooth. We can use things like tooth mousse as well. We can also put in like temporary restorations, which have a sedative effect on the tooth as well. But do we want to do that? I don't know. What about stainless steel crowns? Sometimes we use stainless steel crowns because we don't need to drill. We don't need to give local anesthetic. It means that we can cover up that adult tooth until we decide what we're going to do with it. It keeps it safe. It stops it from breaking down. It stops you from getting any symptoms in it. It's really easy to place. I say to kids, it's like getting a new pair of shoes. You find the right size and then you put it on. It feels a bit strange because it's new. Within a few days, you get used to it. You don't need to do any local anesthetic, as I mentioned, and it helps to preserve the tooth structure underneath. Preserving the tooth structure underneath is important if we're going to think about fillings later on, or extractions later on. If it's about a filling, it means that we have more tooth structure in place to work with. And for an extraction, it means that if there's more tooth structure to work with, we can also extract it without the risk of it crumbling to pieces and becoming a complicated extraction. So we can also place these stainless steel crowns until the cooperation of the child improved, and then we can place a better restoration, because trying to place a restoration in a child who is not cooperating is very difficult, and it will have a compromised outcome. You won't get a good filling on them. So sometimes just buying yourself some time by putting on that stainless steel crown for a few years, then to go back, or putting on that stainless steel crown to stop it from breaking down, is important. We also use it in baby teeth. If the baby teeth are hypomineralized and they have any breakdown, it helps to keep that tooth symptom free until it's time for it to fall out by itself. Okay, so that's why we use stainless steel crowns. I have a little video which explains how the stainless steel crown works, which you can find on my Instagram as well, and the reasons why we choose them. So we put in a nice elastic band first, which I call donuts, and by putting them, oops, sorry, keep clicking the wrong thing, here we go. So the separator just helps to give us a little bit of space in between the teeth where we want to place the crown. It stays in there for a few days or up to a week, could be longer sometimes, but when we take it out, it will give us some space, and then we can select the right crown size easily and just place it on. So we choose the size, we stick it on with some special glue. The child bites on a tooth pillow to make sure it's there properly. You can see a little bit of whiteness just around the gums. That's because it's sitting nice and snug. That's a good sign of a well-seated crown. And you don't need to give local anesthetic. You don't need to drill anything. Your child is not traumatized. It has a high success rate, so it won't become infected if we've got it at the right time. And for the baby teeth, it will wobble out naturally, and for the adult teeth, it will preserve that tooth structure until we are ready to make a decision of how we want to deal with it. So that is why it's a really good treatment option. So what's the point of doing that? You can see you probably, when you go to the dentist, you might get one of these big x-rays of all of their teeth. If that's the case, I'm going to point out to you now which ones are the adult molars. So I'm just going to draw here. So these are the first adult molars. You can see this child has one here, and then we've got one here and one here. Now look at the difference. Can you see the huge hole on the left-hand side? So these two teeth were severely affected by MIH, and these two teeth were not as severely affected. Why? Nobody knows. Sometimes we see one on this side and one on the bottom left side. We don't know. Everybody has different patterns. But on the left hand, on this side of the mouth, what we did was we did sealants. And on this side of the mouth, what we did was we placed something called SDF, which is something which desensitizes and stops caries from spreading. And then I put in a nice glass ionomer sealant on top of it, like a filling. And then on top of that, I put a stainless steel crown. Now, the reason why I put a stainless steel crown as well as having the glass ionomer cement is because what was left was essentially a shell of a tooth. And I was worried that if we waited for that tooth to until the time we wanted to take it out or to restore it, it would be too late, because the tooth would crumble, and because it's just like a shell on the outside. So by putting over a crown over the top of that tooth, it just allows me the insurance that when it comes the time to deal with that tooth, it's not going to crumble under my fingers as I'm trying to extract it. So that's why we sometimes use stainless steel crowns while we're waiting to do extractions, because as we're going to talk about in a few slides coming up, extractions are sometimes an option for these teeth, because we don't want to keep them forever if we know that they're already very, very troublesome, sorry, at a young age. Water, by the way, everyone, plain water. So moving on, why do we want to maybe extract? What is the restorative cycle? Restorative cycle is something that I really want to avoid in my patients, because signing them up to a restorative cycle is just not fair, in my opinion. Having a lifetime of needing restorations is not fun, it's not cost effective, and it's not fair to expect a child to sit in the chair multiple times to get a good restoration. A good restoration, when it's placed in an adult, can have a survival length of time of around 10 to 20 years. When it's in a child, it's probably much shorter, because it's much more difficult to get them to sit still, much more difficult to get a nice dry field and to get a good sticking restoration in there. So this is the restorative cycle. You might start off with a sealant, end up with a filling, and then a replacement filling, then a crown and a root canal together, and then eventually you'll lose that tooth and you'll need to have a dental implant. And you're probably thinking, well, you know, for my child, that's fine. I've had fillings, I've had root canals, and I'm okay. But when you're looking at the restorative cycle, if a filling is 10 years long, let's say, on a good, these are very optimistic rates, by the way. So 10 years for a filling, 15 years you might get out of a replacement filling. You get 20 years out of your root canal and crown, and then 15 years out of a dental implant. That brings your grand total up to about 60 years. 60 years, if you're starting from the age of 7, means you're 67 years old. So 67 years old and you've got a failed implant. And right now the life expectancy is higher than 67, I would hope. And so you are essentially setting your child up for a failure. Whereas if you remove troublesome teeth and allow healthier teeth to take their place, the outcome can be much more favorable, which we're going to talk about next. So when we're talking about planned extractions, we're not just making this up. There is evidence to back up why taking out the first permanent molar, which is severely affected by an enamel defect, can be useful, because it allows the second permanent molar to come forward and take its place if it's done at the right time. And that means that your child will have a lovely healthy tooth in the place of an unhealthy tooth. And it means that they will not need future interventions as long as they are looking after that tooth, brushing it well and flossing it well, which is what we have already learned how to do. So this is an example of what favorable space closure is. So if we find the right time to extract these teeth, we can encourage the second permanent molar to drift forward and take the place of the first permanent molar. So you'll see in the first X-ray at the top, these are the teeth which have been identified to be taken out, the first permanent molars. I'm going to show you them right here. So we've got this one here and this one here. And this over here is the second permanent molar, the one with the line on it, okay? And the same over here. We've got the first permanent molars over here, and we've got our second permanent molar here at the back. Now what's happened is we've taken out the first permanent molar from this area here, and already the number 7 has started to drift forward and take its place, because we've identified the right timing. And over here, you can see that this is the second permanent molar. It has drifted forward and taken the place of the first permanent molar. Orthodontists would be happy, because look, they've got no space left to close up here. So you can see in between the second permanent molar and the premolar, there's no space. So that is a really good favorable outcome, because now the child has lots of really nice healthy teeth to look after, instead of having unhealthy teeth to look after and to be in a restorative cycle. Unfavorable space closure can happen if we do not extract in time. And that means that the second adult molar will not drift forward. And in that case, you're just left with bigger amounts of space that need to be tidied up by an orthodontist. So it's very important that you plan alongside an orthodontist. And these things are very time sensitive. Although we have windows which say like 9 to 10 years, some children can be on the earlier side of those 9 to 10 years old, and others can be on the later side. So it's really important that we check using an X-ray. Another example of a favorable space closure. So these, again, the first permanent molars have been taken out and the second permanent molars have drifted forward and taken their place. There might be some gaps left over, which are teeny tiny, and the orthodontist will not have any trouble closing them up. But a huge whopping molar-sized space is really difficult for an orthodontist to close up. So we've talked about the back teeth and their treatment. Now we're going to move on to the front teeth, because the front teeth are very important as well. The back teeth are important for function, and usually they're the more symptomatic ones because they break down a bit easier, but the front ones are equally important. So remember I said that they are harder to keep clean. So the simplest thing that we can do for our front incisors which are affected, remember I said that they're a bit like a clay pot, which is difficult to keep clean because everything just soaks into it. So this is a patient that I had in last week. You can see that even with very good brushing, he has this lovely plaque buildup around near the gum area, and it's very yellowish in color. So lots of people who have enamel defects will complain that their teeth look yellowish, and it's just because their teeth are very good at clinging to stains. So the first step before you do anything is to do an airflow clean. So airflow cleaning is using a special EMS machine with guided biofilm technology, which is a fancy word for disclosing agent like this. We paint it onto the teeth to disclose, and then we use a special airflow machine which has warm water, which is fantastic for children with sensitive teeth because it feels comfortable and you're able to do a really good clean for them. You can see that this boy's outcome after the airflow was that his teeth are lovely and shiny, they're easier to keep clean, and they also look a bit whiter too. So that's one of the very simple interventions, which is just taking your child to the hygienist regularly for cleaning, which can help to keep their teeth nice and healthy. If we are talking about white spots, because sometimes what we have on the front teeth as a result of the defect is some white freckles or discolorations at the front of the mouth. These white freckles are treated with something called Icon. Icon is a resin infiltrant, and when it goes into these areas which are hypomineralized and it infiltrates them with a resin, it makes them very reflective, and it means they reflect the light, and those white demarcations disappear almost, so you can't see them very much. So it blurs them out. It also protects the tooth. It remineralizes it almost by filling in those defects, makes it easier to keep clean, makes it less sensitive. So there's lots of bonuses to using an Icon treatment. These are some cases which I have done. Sometimes we do Icon alongside some composite. Sometimes we do it on its own. The first case is quite a severe case of an enamel defect. This is it treated alone with Icon. The second case is an Icon that we did, but then we also added a little bit of composite because that defect was quite difficult to mask. You might only be concentrating on the middle two teeth on this case number 2, but actually we treated these teeth as well. And you can see that those white defects that were on it have blurred out entirely. So it's important that we look at all of the teeth when we are deciding what to do and which teeth we're going to treat. In the bottom case, again, we've treated the top 4 teeth, and as a result, we've got those white opacities blurred out a little bit, and more importantly, the demarcation on that top right tooth over here has disappeared after doing the Icon and adding a little bit of composite on top. Moving on, we can sometimes use bleaching alongside Icon. So this is a case of a boy who has a genetic enamel defect. His sister also has the same defect, and the treatment for both of them has been to do one stage with bleaching. So they both have amelogenesis imperfecta. We have treated it by bleaching these top teeth. And again, we've just done the 4 front teeth because at the moment he still hasn't got his adult canines. When he gets his adult canines through, we might have to go back and do something for those. But for the moment, with a boy starting high school, we felt that it was important that we give him some confidence by fixing these demarcations on his teeth. So even just with the bleaching alone, you can see that there was a huge difference in how the teeth are looking. And then when we added in the icon as the last step, that is when it became really obvious that we had improved the situation, and he felt really, really confident about it as well going into high school. He couldn't stop smiling, bless him. So this is a life-changing treatment for most children, and sometimes your child might not request it or say that it bothers them, but for you as a parent, knowing that those options are there is also really important for you to have in your toolkit. So on the day that if your child does come up to you and say, actually, I'm really bothered by this, what can we do about it? Your answer won't be, we can't do anything. The answer will be, we can go to the dentist, we can talk about the options that are available for your teeth, and we can see what we can do. What about baby teeth? Are they hypomineralized, sometimes hypoplastic? Yes, they are. So I see cases with very young children who come in and the parents will say, these teeth came through the gums, and as soon as they came through the gums, they just started to disintegrate. And it's really sad because the options that are available are very limited. Some people just watch and wait, but for me, I'm proactive. I don't want to watch and wait for them to crumble. So what I do is something called a strip crown. A strip crown is essentially a clear crown form, which is in the shape of a tooth. We select the size to fit the tooth that we are trying to restore. We place the material in it, which in this case is something called Equia Forte, which is that glass ionomer cement I spoke about earlier, and it is resin modified, so we can actually light cure it as well, and we get really, really good results. So you can see on the top left picture over here how the lateral incisors were very broken down, and I hope that you can see even on the central incisors there was a defect. We covered those up. By covering them up, it gives the child a chance of keeping those teeth until they're ready to fall out, because they're not going to break down any further. They are not going to be sensitive. They are going to allow them to be brushed, which is really, really important, because we get lots of children who's you're struggling with brushing, and the reason why you're struggling with brushing is because the teeth are feeling sore and the child just doesn't want to have them brushed. So yes, you do have to push them to brush them, but you can also do things to help them to make them feel more comfortable as well. So excuse the pictures. My husband always tells me off for my photos, but then I have to remind him that, you know, my patients, when I'm taking pictures, for example, in these two, were 1 year olds. So it's really difficult to get a 1-year-old to pose with their teeth. I have lots of videos available on my Instagram and Facebook, which will give you some tips on how to brush for your children, just lots of different motivational tools for you, and also the things to look out for when you're brushing their teeth. So please look out for those. Really important that you find a dental home for your child, because going forward, children with enamel defects have treatment needs, and they need to have those treatment needs met. They need to be really nice and comfortable in the place where they're having those treatment needs met, which is why having a dental home is important. These are pictures of the children who come to see me. The reason why their pictures are up on the wall is so that they have a sense of community. They absolutely love it. When they come in, they're all looking for their photos up on the tree. They're looking for their friends, their neighbors, their classmates, their schoolmates. It's a really, really lovely sense of community, which I'm very proud to have built. How do you feel now? So we're gonna share another poll. I'm going to ask you how you feel again. Okay, so we're going to clear the results. Let's see if I can do that. Relaunch the poll. Let's see if we can do that. Relaunch it. Okay, here we go. How do you feel now? I hope that the diet and oral hygiene advice has, and the advice about sealants, about fluoride applications, tooth mousse, I hope that this has made you feel empowered, that there are other things that you can do. There are treatment options. I hope that your confidence has improved after listening to me for the last hour and a half. And I also am mindful that I want to leave lots of time for questions. Okay, excellent. So I can see lots of 1s and 2s and 3s. I'll give you a moment more to answer, or half a minute more. In the meantime, if anybody has any questions, please pop them through into the Q&As. Very good. So we're definitely much higher up in our confidence, which is great. Let's end that poll and I'll share the results with you there. So you can see that we've definitely gone up the scale. So I hope that you're all feeling empowered and you know the things that you can do to help your child to have awesome oral health. I'll quickly ask you about prevention. Were you aware of these prevention tools of topical fluoride at the dentist, fissure sealants and tooth mousse? So were you aware of them before you attended this webinar? If you were, just tick the ones that you were aware of. We'll see what everybody says about that. So that's great that I would say most people are aware of topical fluoride varnish and fissure sealants. Less so of the tooth mousse, but still about half of you aware of the tooth mousse, which is fantastic. That's great. So just keep that for a few more moments. That's great, actually. Most of you are aware of these things, which is fantastic. We'll end that poll and I will share the results with you. So you can see there, lots of people know about fluoride varnish. Some people, 3/4 almost know about fissure sealants, and just over, well, 2/3 know about tooth mousse, which is great. Now, let us ask you one last question, which is, which of the following has your child had? So those prevention things that we mentioned, which of those interventions has your child already had or do you use already? So the fluoride varnish, you might know it as the child smile if you're here in Scotland, which is the banana Durafat paste which they paint on at school, at nursery, at the dentist. So that is what the topical fluoride varnish is more commonly known as. And the fissure sealants are just on the back first permanent molars. Now, I'm very mindful that I've spoken a lot, but this is such a huge topic as well at the same time. So I could sit here and talk about it for days. I'm attending a 4-day conference on it in Munich in December, which I'm really, really excited about. So hopefully I'll come back with even more information and more ways of helping children who have molar incisor hypomineralization, amelogenesis imperfecta, and all the other defects of enamel. So that's the results of that quiz. Thank you so much, everybody, for answering. And the last thing I'm going to do is I'm going to ask you if you are concerned about the aesthetics of your child's front teeth. So this is information just to see if it's something that bothers you and your child, or just you or just your child, neither of you. Not a concern at present, but it might be in the future. So what I find is really important isn't that you treat everything, but that you know what treatments are available, so that when your child does ask you, you know, can I do something about this? You have an answer, which is, yes, we can always do something, and we can speak to the dentist about it. So having some confidence and making sure that they're happy. So that's excellent. I'm just going to share the results. So about 1/3 of you said that you have concerns. It might not be a concern, but it might be in the future. And then a few less people said me and my child. Very few said just their child, and neither of them. So very interesting. Thank you so much, guys, for participating in that and for sharing that information with me. And I hope you've enjoyed the webinar so far. The next part is going to be about questions and answers. I do have enamel care kits available, which you can purchase through our Sunrise Dental Clinic website. So if you go to sunrisedental.co.uk, and if you want to order a tooth care kit, I've included a leaflet about looking after your teeth, my sugar bug poo story, the fun flossers, which I recommend because the kids find them easy to use, some disclosing tablets, a lovely bamboo toothbrush, and tooth mousse, which I love. Tooth mousse comes in different flavors as well, so you can choose which flavor you want. And if your child has any sensory issues, I would highly recommend that you use Oranurse, which is an unflavored toothpaste, which also has no foam, which can help sometimes if you've got any sensory issues going on. In terms of toothpaste, try and find a toothpaste that your child enjoys using. Otherwise, they will not use it and it's pointless. So try and find one that they actually like to use. And that will also come with the information on how to use the tooth mousse as well. Excellent. So questions. Where are you, Dr. Ryan?
Trying my best to answer all these questions as best I can. I've got loads, but I'm going to try and group them in. There was quite a few of a similar thread coming through. I know it's a topic that you're quite passionate about besides teeth, but breastfeeding mums, breast milk and enamel hyperplasia. What happens if they've already got an enamel defect, and does breast milk affect teeth?
Okay, so anything that pools in the mouth that isn't water during the night will become acidic. If your child's teeth are really strong and healthy and fantastic, they will be able to withstand that time of demineralization throughout the night. If they aren't, then it's possible that they won't. So it's just like an added risk factor. And if you have an added risk factor, what did we say? We said we have to balance it out with something to remineralize the teeth. So my advice to breastfeeding mums, and I'm talking about when we're breastfeeding past the age of 1 through the night multiple times, or feeding to go to sleep after brushing, I recommend that they wipe the gums and teeth using a wet washcloth to get rid of any extra milk in the mouth, be it breast milk or bottle milk or any kind of milk, because we just don't want anything to sit on the teeth and become acidic. So wiping away the excess using a wet towel if you're unable to brush again. And another idea is to use tooth wipes, so gum and tooth wipes which have xylitol in them, which are available from a company called Brush Baby, because they will clear away any extra milk in the mouth. And also adding in tooth mousse, so you can put on tooth mousse to your child while they are asleep. So even if they're asleep, if you just put a smear of tooth mousse on their teeth, that will protect them and reduce any acidity that is caused in the mouth. So the answer to that question is breastfeeding is fantastic. I have nothing against it. If we have a risk factor like the enamel is hypoplastic or hypomineralized, it just means we have to be extra careful. And that can mean that we either need to cut down breastfeeding. If we can't do that, or we don't want to do that, that's fine. But what we need to do is to counteract the possible risk factor by adding in more protective factors. Okay, I hope that answers the question, and it hasn't made even more questions.
No, thank you. What if someone has an intolerance to or an allergy to dairy? How can they use tooth mousse, and is there an alternative?
So the answer is no, you can't use tooth mousse if you have an allergy or intolerance to casein. That's the part of the tooth mousse which aggravates people who are intolerant to milk. So what we could probably use instead is something called Biomin, which is a toothpaste which also remineralizes the teeth, but that contains fluoride, so that would be instead of toothpaste rather than adding in tooth mousse as well. However, I'm not entirely sure of the mechanism of that, so my answer would be probably be more careful with diet and oral hygiene if you can't use tooth mousse as well, and maybe add in an extra brushing during the day.
Okay, thank you. I'm trying to find some questions that might help a number of people.
So what I will actually say is, if the dentist, I can see there's quite a few questions from some dentists. Dentists, please can you just copy your question and email it across to me, and I will answer you privately. because it's about things like where to source materials, things like that, which I don't think everybody else will find interesting. Somebody's asked about electric toothbrushes versus manual toothbrushes. I always say, I'm a scientific person, I say brush your teeth with an electric toothbrush and chew a disclosing tablet and see how much sugar bug poo is left on your teeth, and then another day use a manual toothbrush and do the same experiment, take photos and compare them and see which is doing a better brush for you. Most of the time it's the electric toothbrush, and some parents are worried about pressing too hard with the electric toothbrush, but nowadays you can get electric toothbrushes which have a sensor on them which will flash up in red to tell you that you're pressing too hard, and so it's not really anything that you should be concerned about. So I think that that has answered that one. Somebody's asked about fissure sealants and how long they last on teeth. It varies from child to child, from day to day, from month to month. My child will wear away the same 3 each time. Other times she'll come in and only 1 will have worn away. That's why they need to be monitored every 3 to 6 months at least, to check that they are sitting there nicely. Sometimes all 4 of them need to be replaced, sometimes just 1 of them, sometimes none of them. So it's really, really hard to predict. What about you, Ryan? Do you think, is there any more questions from your side?
There's a lot of people very, very grateful that you've spoken about this today, because it's perhaps the first time they've had any insight to it. And of course, a lot of kids are affected by these things. Despite all their good brushing and flossing, they've still got these things on their teeth that a lot of people perhaps have not understood before. But yeah, really good feedback. Lots of questions on which toothpaste, which toothbrush, and yeah, it really comes down to the individual person.
It comes down to individual preference. When it comes to toothpastes, just making sure it's a toothpaste that your child likes, because otherwise they won't like brushing with it. And sometimes changing it to check whether it's maybe too foamy, maybe it's just the wrong flavor, just trying different types until you find the right one for your child, but just making sure that it has the right fluoride level requirement in it, which is 1,000 parts per million fluoride when you're 3 and under, because you can't spit, and 1,450 parts per million fluoride if you are over 3 and you can spit. So just check on the back of the packet when you're buying it. Otherwise, it really comes down to taste and things like that. So
yeah, there's a few kind of clinical questions which of course we can't answer without doing an examination, but I would just suggest, if anyone is concerned about their child's teeth, to try your best to see your dentist. If that's difficult because the dentist isn't able to see patients, or you don't have a dentist, you may then have to look outside of the NHS. Some dentists may work privately and can see kids too. And of course, if anyone is in real pain, then you can access emergency services in those situations as well.
Yeah. Just be careful if your gut feeling is that if your dentist is unable to give your child the treatment because they're not very cooperative, do bear in mind that pediatric dentists have special training in behavior management, which is why you can ask for a referral to the dental hospital through the NHS to get the treatment that your child needs, or try and find a dentist who is more experienced with dealing with children, because that can make the difference for the child. Maybe a bit of extra time spent in the right way can help to get the things addressed. But I would say 9 times out of 10, mums and dads, trust your gut feeling. If you feel like you're not happy with not doing anything about your child's teeth, please try and push and get the treatment that they need. And make sure that in addition to that, you're doing your end. I always say it's teamwork. So you guys need to do a big part, which is the diet and oral hygiene. That's all in your control. I say to children, I wish I could go home with you and make sure that you've lost, but I can't. I just need to make you motivated to do it. So you do that part and find the right care for your child with a dentist that you feel comfortable with. A dentist is a really personal choice because it's in a personal space. So not every child is a good fit with every dentist. So it's not wrong to move on to find a different dentist. I say that to, you know, parents and children all the time. I say you have to feel comfortable with me because I'm going to be in your child's mouth. Your child has to be comfortable with me because I'm in their mouth. It's a very personal, sensitive space. So it's really important that everybody's feeling good about where they are in that relationship. And if you're not feeling comfortable, then do move on. And I never take it personally if a patient moves on to another dentist, because I understand that it's never going to be a perfect fit with every single child and family. So definitely push for what you need for your child. Any more questions, do you think, Ryan?
No, you're just getting rave reviews.
Oh, fab. People are asking if it's going to be recorded. We have recorded it, and I think what I will do is we'll send out a link to everybody who has joined tonight with the information of how to access that recording. Just bear in mind that the recording will not be available for a long period of time. I think it might be around a few weeks or a month. And then after that, it will be offline. You'll also receive an email with a link, which will, if you want to buy some of the enamel care kits, or even if you just want to buy one component of it, you can have it delivered to your house, or you can come and pick it up from the clinic if you're local to us in Edinburgh. If you do have any other questions, you can also email me directly. I do get lots of questions about, you know, kind of trying to give a clinical evaluation of things. It is really hard to do that. And, you know, I'm very happy to see your children for consultations, but I don't feel comfortable giving too much advice specific to a case unless I've actually seen them in real life, because it does make a difference. So please bear that in mind when you're asking me questions, please. Excellent. So thank you so much. And hopefully this has been a really positive experience for you all. Hopefully you're all equipped with loads of ideas and, you know, things that you can do yourself. And I wish you all the best. I'm also on a couple of the Facebook groups like Enamel Hypoplasia and Hypomineralization Support. There's one for the UK and there's one that's international. I'm on both of those groups, and I do interact with posts there. So when people you know, write things up, I do answer and interact. So happy to help you all. I think, should we say goodnight, Ryan? Do you think that's it?
Yeah, definitely. Thank you so much for all the questions and for joining. Yeah, it's really good.
Perfect. I'm very, very happy everybody's come and had a great time. Thank you, Ryan. See you tomorrow.
Bye. See you tomorrow.
Excellent. Bye, everyone. And thank you so much for joining.